Hello everyone, welcome. Today we shall review this case of a pre-operative embolization of a large craniofacial tumor in a 71 years old female patient using a combined direct puncture and transarterial embolization technique. So these are the pre-operative clinical images. We can see this large mass involving the temporal region, the frontal region, the upper cheek, zygomatic area, and the upper eyelid. So, in our multidisciplinary meeting, it was decided to do embolization of the tumor and operate next day under general anesthesia. The surgeons plan to take out the entire tumor, but possibly a part of the tumor involving the lid could be left behind uh, if it is found difficult to operate it out surgically. The embolization was planned using our combined technique, as I have already discussed, that we use direct puncture embolization with glue and combined with transarterial microcatheterization and embolization with PVA particles. These are a couple of representative MRI images of the patient done preoperatively. We can see this large solid mass in the right temporal region extending to involve the lateral orbit. We can see there are multiple flow voids within. The tumor is hyperintense on T2. We cannot have a clear definition of the margins of the tumor, suggesting that it is partially infiltrating into the surrounding normal structures. And on the post contrast image on the right side of the screen, we can see that the tumor is taking up contrast vividly. The patient was taken up for embolization. These are the representative DSA images of the right common carotid artery injection for vascular mapping. Tumor is obviously better defined on the selective injections of the external carotid artery injections, which we have taken here. We can see that the tumor is enhancing brilliantly. On the right side of the screen, the lateral frame is there, which is showing the extent of the tumor, although this is slightly early phase than the one which is on the left of the screen, which is the anteroposterior projection. These are slightly later phases of the DSA. We can see progressively enhancing tumor on the DSA. The contrast uptake keeps on increasing, giving a dense parenchymogram. We can also see on the image on the right that which is at a slightly later phase of the lateral DSA run than the previous slide, but still it is relatively early. This image is shown to give the extent of the tumor. You can see the lobulated margin on this, and the tumor is approximately 12 by 11 centimeter in size. The advantage of DSA in this is that it is able to define the margins of the tumor, which is not seen on the MRI, but we can see that the vessels are extending till the margin of the tumor, and so we know where we have to embolize and where we have to operate. On the first image on the left side of the screen, we can see the tumor enhancement overlying the bones of the craniofacial region, which is just given here to depict the extent of the tumor vis-a-vis the bony structures. The middle image is an anteroposterior DSA run with a puncture needle has been done in the center of the tumor, and contrast has been injected to delineate the tumors. The same is seen on the lateral frame. So this is a biplane DSA run, a direct parenchymogram with direct puncture of the needle. Once we know how the runoff is there with the direct puncture, we can progress to inject glue, which is in my practice 20% N-butyl cyanoacrylate mixed with lepiodol, but sometimes it varies from 15% till 50%. Occasionally I also inject 100% glue to knock off some vessels, which is internal ligation, or if there is a high flow shunt in the tumor, or if I'm dealing with a very high flow craniofacial malformation. we obviously use road mapping or smart mask techniques to overlay the vessels and the tumor. Here we can see on this centroposterior and lateral frame, we can see the glue is being injected, and white structures seen are the blood vessels and the tumor parenchymal vessels, which is basically the smart mask technique of the DSA image which we have used. We can see on this that there is a very nice progression of the glow injection in a lot of vessels. Most of these I can tell are veins, they are not arteries, and these tiny ones next to the larger channels may be some of the arteries which are shunting into the tumoral veins. So progressively there will be thrombosis and decrease in the parenchymal perfusion using this technique. But obviously this is only the core of the tumor. We still have a large part of the tumor to be embolized. The fluorospot unsubtracted images, we can see now that there is a globular kind of um, glue filling at the center, which means that now no more injection can be done from here. The vessel there has ruptured. This is not an uncommon finding in these kind of tumors. They are not high flow AVMs, so this happens. We try to avoid it, but and it happens, and usually it does not cause a lot of problems. We have very nice percolation into a lot of blood vessels in this particular tumor, and so I'm satisfied with the way the embolization has progressed till now. An angiogram taken after this single puncture embolization. This particular injection was quite prolonged, so which is also quite common once you have done a few embolizations, that you can keep on injecting glue, unlike when you are at the start of your career when the needle jams immediately. Once you have utilized glue in few patients, you learn how to manipulate the concentration and the pressure and the visualization of the runoff and all, and then you can manipulate your injection techniques, and then you know that you can achieve very prolonged injections and reflux into compartments which are not the primary puncture compartment, but through different collaterals. Similar kind of thing can also be done for arteriovenous malformations, not only for these direct puncture superficial lesions, but also in the brain or deep-seated body arteriovenous malformations and tumors as well. So here, but the central part only is embolized, and we still have a lot of tumor to cover. Native unsubtracted fluorospot images. We can see here there's an interesting finding. So there are three more blobs of contrast or glue. One of them was glue at the bottom. Others are contrast, which we inject and then try to see where the contrast is going, but it's just going into the parenchyma, not into vessel. So this is a very important image to understand that unless we have a runoff into the vessel, we should not further inject glue. And so we keep trying. Unfortunately, here we have to make 4 punctures. We can see on the lateral image that there are 5 such blobs. One of them was from the previous glue embolization, and 4 we have attempted to inject contrast, but all of them were unsuccessful. DSA, just to check that we have not caused any harm, and we still see that the core of the tumor is embolized and the large part of the surrounding areas and the superior part of the tumor is still unembolized and filling. So now, because we are unable to get any nice vessel visualization on direct puncture, we switch over to transarterial microcatheterization and embolization with particles or glue or coils, whichever we deem feasible. This is one of the microcatheter injections. My usual practice is to use a prograde microcatheter, which I have found is very suitable for these cases. Some neurointerventional radiologists do not use prograde because they are not aware of it. It is a peripheral microcatheter, but it is very useful in these kind of situations. So this is one of the microcatheter injections. It is filling the tumor. We have to be careful what size of the particles and all we are embolizing. that it should not reflux into the dangerous anastomosis, it should not cause skin necrosis, it should not cause nerve palsy, etc. etc. We can learn a lot about that. But usually in these situations, if you are just seeing the tumor enhancement, you know that the tumor is going to be excised, and along with it, the skin over the immediately over the tumor is also going to be excised. We just to be sure that we are not going into the normal skin and the normal structure. That's all. On the left is another micro injection. There may be different appearance. Some may be very sharp vessels, some may appear this fuzzy kind of appearance, but they're all depending upon the size of the vessels. So we keep on microcatheterizing the appropriate target, and we keep embolizing with PVA particles. Usually I go with 100 or 200 micron size. Initially I used to embolize with large size particles, but as my experience has increased, now I have shifted towards the lower size particles, which have provided me with good surgical outcome. uh, and I have found that complications are not that common with smaller particles. In usually in once I have done all this glue embolization to knock off most of the larger vessels, then the PVA particle is just taking care of these smaller vessels, and I'm not really um, no, I've not really seen major complications till date, barring one case. ECA injection after embolization completion, we can see that most of the tumor is now gone. The blush is the normal blush of the masseter and the parotid and the occipital region. We can see that there is some pruning of the STA branches, which was unintended, but it has happened. But usually there is no consequence in this because the distal territory is being perfused via collateral. So we can see there is practically no filling of the tumor now after the embolization. Common carotid artery injection control, we can still see the needles which are embedded within the tumor. We can see all the normal arteries are filling. We can see that the tumor is completely devascularized. Obviously this is a global run, so the better visualization is on the selective ECA and further injections downstream. But this is just to show that we have not caused any complications and such things, and also to produce a nice image for the social media and paper publication and presentations and all. Of the glue cast, we can see the some of the contrast blobs as well as lot of glue. You can see here that the glue has further migrated in the small vessels, which I have noticed in some of the cases. The longer the procedure goes, even after embolization, we feel that the glue has solidified, but I have noticed in some cases that they keep migrating into the smaller vessels even after you have closed the injection. So we can see nicely some of the needles which are still there. Obviously I will remove all the needles once these are done, the procedure is done. One important thing is know that all the needles are left behind until the end of the procedure. I'm not removing the needle after injection from them. It is just to prevent bleeding and complications. Also we know that which areas we have punctured, which vessels we have punctured and such things. So to demarcate the embolized thing where we have caused these vessel ruptures and all that stuff, it is important. You can see with this image, the upper part of the tumor does not have any glue cast, so that part was basically embolized with the PVA particles through microcatheter injections. Patient underwent successful surgery with minimal blood loss. The entire tumor could be excised. So my technique for these superficially located tumors and vascular malformations for that way is very simple. I try to use direct puncture embolization wherever possible, sometimes with one needle, sometimes with multiple needles depending upon the necessity. The material used is NBCA with lepiodol mixture. Usually it is 20%, but sometimes can vary depending upon if there are high flow shunts and all. Uh, with the needle puncture, I always inject contrast to see where the contrast is flowing, with what speed, what pressure I have to use, and how much volume it can take. and then I have to check the collaterals and the dangerous anastomosis. I will always have a catheter in the artery to take control imaging, and sometime I will use roadmap, sometime I will use a DSA mode while injecting the glue for finer visualization, keeping in mind the dangerous anastomosis. Uh, with time and repeated procedures, now I have learned how to give prolonged injections of glue and channelize them into different compartments, same as what we do with onyx. Uh, Not the same, but akin to, or in some cases we can achieve extensive embolization with a single puncture, but usually multiple punctures are needed. PVA particle embolization is done to knock off some of the peripheral vessels. Occasionally, we do internal ligation of some of the surrounding vessels with coils to reroute the embolizing material towards our desired compartment to the desired vessel, and to prevent unwanted territory embolization, etc. We have done more than 100 cases at AIIMS Patna, and thank you for watching.